Okay, so when we left off on Friday, we were talking about um, intubating the horse and maintaining on gas anesthesia, which typically they're going to be on a ventilator. And pretty much the ventilator takes the place of the breathing bag. When we hook up ventilators, and again, if you go into a practice that's going to use ventilators, you'll get training on site. But a ventilator manually ventilates the horse, um, primarily because they tend to hypoventilate. They have a lot of weight on their diaphragm, and they have to ventilate well in order to maintain adequate perfusion, adequate oxygenation. Part of the problems when we talk about myopathy and neuropathy, which that can be from inadequate padding, that can also be from inadequate perfusion to the tissues. And again, perfusion is adequate blood pressure and adequate blood flow to every tissue. So we want to make sure that we're maintaining these parameters. And remember, horses are prone to atelectasis due to this hypoventilation and due to the excess weight on their diaphragm. So leading into monitoring, what we're looking at here is horses are prone to these three, I call them the three hypos, basically hypoventilation, hypotension, and hypoxemia. So, we've talked about monitoring a while back, but some of the monitoring parameters here is hypoventilation is going to be worse when they are in dorsal recumbency, and that means when they're on their back. So if you're doing abdominal procedures, but even if you're doing a procedure on on a limb, and like they're working on a joint or a fracture repair, and they are positioned in dorsal recumbency, it's going to potentially be worse. So this is why we use mechanical ventilation. Now, what parameter do you look at? And this pertains to dogs and cats as well. What do you look at when you're assessing hypoventilation? There's one key parameter that we're going to monitor that's going to tell us if the animal is ventilating. Maybe it's too early in the morning. So your end tidal CO2. So CO2, these horses are going to be hooked up to a capnograph. And in dogs and cats as well. When you look at your CO2 number, CO2 is supposed to be, and it's same for the horse as it is in the dog and cat. It should be 35 to 45 is normal CO2. The higher the CO2, the more of a degree of hypoventilation, because to get rid of CO2, you have to ventilate. That's the only way you get rid of CO2. So that's how we gauge how well is the animal ventilating, and do we have to assist ventilation is the degree of CO2. And again, 35 to 45 millimeters of mercury, and that will be on the test. What is normal CO2? And basically, the higher the CO2, the higher the degree of hypoventilation. Now, hypotension is relating to blood pressure, and this is what can contribute to myopathy. Not only pressure on the muscles or inadequate padding, but inadequate perfusion to the muscles. Now in the horse, I've told you in the dog and cat, you never want your mean, your MAP, that's the number to the side, you never want that to be below 60 in a dog and a cat. In a horse, it's higher. We don't want that number below 70. So if we have a mean blood pressure below 70, there is going to be a greater risk of myopathy in that horse post-op. And that's what we call tying up. If their muscles are tied up, if they're tight, constricted, that's kind of a sign that the horse did wake up with myopathy. So good perfusion is going to prevent that. And then hypoxemia. Now, some of you may, when I said, what do we monitor to say how well the horse is ventilating? If you were thinking oxygen level, remember, oxygen levels don't drop as sensitively as CO2 so an animal can be having hypoventilation, and can actually have a fairly normal SpO2. SpO2, or oxygen saturation, is not as sensitive um, as an indicator of ventilation as CO2 is. So CO2 is going to be a much more sensitive reading. Eventually, it can affect their oxygen saturation. Now, if you remember, hemoglobin on a red blood cell carries oxygen. And when we put the little probe on the tongue, this is how we measure. So how do we measure? Well, we want a PaO2. If you remember from monitoring, PaO2 is arterial saturation. Now, we don't want it below 80 on an arterial sample, but on an SpO2 probe, we don't want that to be below 95. So 95 to 100% is normal. 90 to 95 is slight hypoxemia. And if you had 85 to 90, that is severe hypoxemia. And remember, 85 is like, you absolutely don't want it to go below 85. So again, if they're overweight, if they're pregnant, if they've got a torsion colic, so twisted intestines is called a mesenteric torsion. So the mesentery supports the intestines. If those twist and it compresses the blood, it can set up a hypoxemia. So you do need to remember the difference between PaO2 and SaO2. Now, what do I do to increase blood pressure? What's one of the first things you can do if your horse's blood pressure is falling?
Fluids?
Fluids. You can do fluids, fluid bolus. What about your anesthetic? What do you do to your anesthetic level?
Turn it down.
Turn it down. Who's talking? Thank you for speaking. I appreciate you.
You're welcome.
Thank you. People are alive. People are alive. Okay, so blood pressure is a common, and you know, in 3 weeks, you guys are in surgery. So in 3 weeks, you're living this, not with a horse, but you're going to be living this live. So if you have an animal that has low blood pressure, one of the first things I do is I try and turn down my gas, because one of the most hypotensive agents that we use are inhalant anesthetics like ISO and SIBO. They're fantastic, but they cause vasodilation, which drops blood pressure. So sometimes you can just turn down. Now remember, in a horse, when you turn down your gas, it's not like an instant fix. Now in a dog and a cat, you can probably see an improvement potentially in 5 minutes or so. In a horse, it may take 10 or 20 minutes to see a change. You can also do a fluid bolus. I always check with my doctor. I'm not just like giving fluid boluses willy-nilly, because some animals, you know, if you have heart disease or low protein, you know, those are animals that sometimes you don't want to bolus too many fluids. So, you know, you always check with the doctor. But those are like the first two things. There's a note under here about a drug called dobutamine. So there's two drugs, dobutamine and dopamine, that are called positive inotropes. And what they can do, dopamine will increase, it'll increase vascular tone and perfusion to the kidneys. Dobutamine helps the heart beat a little bit stronger to see if that will improve the blood pressure. But those drugs are usually usually we turn down gas and we give fluids and try to do it that way. But that's a common problem. So I do want you to know those parameters for this test. Now, you guys, when we talked about measuring blood pressure, most often in a dog and a cat, you use a cuff. You just put, and if you remember, that's called oscillometric blood pressure. So it's an estimation. It's what's called indirect blood pressure, because you're putting it around a limb to get an estimate of blood pressure. And those are fairly accurate. But when we have a species like a horse, and we really need to know blood pressure, most often we do what's called direct blood pressure monitoring, which is a catheter in an artery. And when you put a catheter in an artery, now remember, arteries are pushing out. These catheters that you see are not for giving drugs. This is purely for monitoring, and you can also get what's called a blood gas sample. So when you put the catheter in the artery, it's kind of cool because when you look at the catheter, sometimes you see a little fluid in the catheter. You can actually watch the pulse because the blood is pulsing. So what is set up here, okay, there's 3 arteries. We've got the facial artery here, which is also, we kind of sometimes call it the submandibular. If you see there's a catheter here. There's also in B, this is called the transverse facial, and it goes right under the eye. So if the horse is in lateral, you can use the transverse facial. If the horse is in dorsal, you can use this mandibular or facial artery. And then if they're working on the head and the neck, you can use what's called the dorsal metatarsal artery. And this is over the rear limb. Now, all these arteries are what are called superficial arteries, meaning you can't, and these are also areas that I can palpate a pulse. Remember I said after you induce anesthesia, you want to feel a pulse? Well, you can't always put your hand on their heart, and you can't feel a femoral artery. Their leg is too big, they're too muscular. So the superficial arteries, I tend to go like under their jaw with this facial artery, and I tend to sometimes just go on the side of their face, and you can feel a pulse. Now, I will explain here. There's a stopcock here, and there's a white cord called a transducer. So what's happening is we have a bag of hep saline pressurized, and it's under pressure because an artery, if you watch what I'm doing on the screen, an artery is pulsing out and fluid under pressure is being pushed in. But when you push fluids in, fluids aren't going in. This is an arterial catheter. So what happens is as the artery pumps against the fluid going in the catheter, there's pressure, and the transducer here measures that pressure, and there's a cord going to the monitor. So on the monitor, you're going to see a pulse wave, and it's going to give you systolic, diastolic, and mean blood pressure. But because it's directly in an artery, this is the most accurate form of blood pressure monitoring. And again, it's an advanced procedure. Now, we did this, if you work in an advanced practice, we did this on our surgery, some of our surgery patients at Purdue, small animal patients. I've even put them in cats before, and techs can do this procedure. I was trained to do this at Purdue as well. This is kind of an advanced technique, but I want you to be familiar with what superficial arteries we can use and kind of what's the theory. So the other thing that you can do with this is you can do what's called a blood gas. Now, if you remember when I talked about oxygen saturation, I said the probe on the tongue is an SpO2. But remember I said if you want to take an arterial sample and you send it to a blood gas monitor, you can draw blood out of this arterial catheter and you can measure their actual arterial oxygen, their PaO2. So the nice thing with, and normally with horses we do that. We usually do blood gas measurements and direct blood pressure to make sure that we are, we're assessing oxygenation. And a lot of times they have an SpO2 on their tongue because, that'll give us an estimation. But if we're concerned, especially for a colic or a very, a pregnant horse, and, we sometimes want to know if they actually have, good blood pressure. So are there any questions about the monitoring values that you need to know or remember? So indirect would be a cuff on a limb, and direct would be using one of these superficial arteries and going in, and then you know the numbers that you need to know for monitoring. So now if we're going to maintain with, now we talked about field anesthesia, and TIVA, again, we typically want the procedure under an hour. So if you're just going to use Now, this can be in the field. This could still be in the hospital, and it's a shorter procedure. But we use a combination called triple drip. And again, triple drip is typically guaifenesin, ketamine, and an alpha-2. Xylazine is the most common, but romifidine is a large animal alpha-2. So as long as you have an alpha-2, ketamine, and guaifenesin. Now, if you remember, guaifenesin is not an anesthetic. It is a muscle relaxant. So it's added to triple drip to kind of enhance relaxation. Because remember, ketamine, muscles are very rigid. So if you're using ketamine in an animal, we're usually mixing it with something to enhance relax. Now, the xylazine will give muscle relaxation. Guaifenesin is just going to enhance the relaxation. And remember, which of these three drugs can be given to effect? There's one of these drugs that you give to effect.
Guaifenesin?
Correct. So in the horse, we use a bolus technique to induce anesthesia, except guaifenesin is usually just dripped in until they're relaxed enough, and then you can stop it. Now, this tends to have good blood pressure, less respiratory depression. They do have active palpebral reflexes. If you remember, ketamine, they retain a little bit of their reflexes longer, so you will potentially see some palpebral, but it does have a good recovery because the drugs have a little bit of a hangover effect. You know, these drugs are not rapidly metabolized. So, you know, a good recovery in a horse is they don't wake up too fast. And that's considered a decent recovery, that they don't wake up thrashing and trying to stand too early. Now, if you want to extend anesthesia, if you want to go a little longer, then what they will do, they'll either give a little more xylazine, a little more ketamine, or they may give a little more of both. So you can extend anesthesia time with just, and remember, Tiva, it's all injectable. So you're only using intravenous agents to keep them asleep. Now, a very common way when we talk about inducing a horse for gas is that they will still use triple drip. So they'll still bolus it in. They can continue to infuse triple drip like a CRI and then intubate and put them on inhalant. But if you decide to run triple drip during the procedure, it's just going to help decrease the amount of inhalant, keep good analgesia, keep good muscle relaxation. So sometimes triple drip is run, it's bolused in for induction, and then the drip is continued during the procedure. Now, sometimes in horses, they will actually run lidocaine as a drip. Now, remember, I told you guys lidocaine is normally a local anesthetic, not given intravenously, but there are a few, it's part of MLK. So the lidocaine, and this isn't MLK, this is just lidocaine and detomidine. Now, detomidine is a large animal alpha-2. So it has a lot of the same effects as the other alpha-2s, but it's specifically for large. Remember, xylazine is used for both. Dexmedetomidine is small animal. Romifidine and detomidine would be pretty much just large animal alpha-2s. But this can help decrease the inhalant requirement because you're giving something intravenously, and it helps give some analgesia. Okay, so the thing that I told you is very, very important is that, you know, when you position them, obviously we want to try and keep them comfortable, but some keys is you definitely want to control the head and protect the eyes. If you remember in that video we watched last week, he kind of held on to the mane as the horse was dropping because, again, their eyes are very, you know, since they're kind of lateral and they have a very large eye, we don't want them scraping and getting any corneal abrasions. So you want to make sure that you protect the eyes. Now, when they cover the eyes with a towel, that does help protect the eyes, but the other reason they do that is to try and keep it dark, and it helps them become sedate a little bit better. You know, if it's dark, it's not bright, it just helps enhance them falling asleep. So the towel that you saw in the video over the eyes, you know, is twofold: protection and to keep it dark and help enhance sedation. Now, typically the hobbles, which go around the fetlock area, you got to make sure that those are put on. Again, that will not hurt the horse unless they're put on improperly. So they have to be put in the proper location so that the horse can be hoisted. And then the key is the padding. Um, so some of the rules I've told you, every surface has to be padded. Um, when they tie the horse, if the legs are going to be, they either leave the legs natural, they just kind of let them drop like this. If they do tie them, they're not stretched. They're usually tied in a natural position. So you don't want to extend the legs, overstretch them, over, you know, any rope that is put around a limb can put pressure on a nerve. And that's when we worry about neuropathies. And obviously the myopathy, part of that is padding. Part of that is blood pressure and perfusion. So the big things we worry about post-op is we worry about these myopathies and these neuropathies. Now, as far as recovery, this is where things get really dicey because they they are hot wired physiologically. They want to stand the minute they think they're awake, and the problem is sometimes they're not awake and they think they're awake. And so it's going to be very, very key to try to help them wake up slowly. The other thing is they're obligate nasal breathers. Now, while a horse is intubated, they are breathing through the endotracheal tube. Once you pull the endotracheal tube, and again, it's the same, you know, 3 swallows, you start to see movements, you start to see the tail moving, you start to see the head moving, but especially you're looking for swallowing. Once you pull that endotracheal tube, they have to be able to breathe through their nose. So you have to make sure you look for any nasal discharge, flaring nostrils, and it's the same rule that I talk about in small animal. Anytime I pull a tube from an animal, you need to continue to watch their respiratory rate and especially the respiratory effort. If they were breathing nice and relaxed when they had a tube in, and then you pull the tube and they start like abdominal breathing, or in a horse, they start really flaring their nostrils, you need to be cautious because again, you just took their airway. They have to be able to maintain their own airway. So you're never going to just like pull the tube and be like, see you, I'm on to the next procedure. You need to continue to monitor how they're breathing, because I've had plenty of instances I've had to re-intubate animals on recovery because they just didn't look good. They didn't have good color. They had, you know, increased effort. So you have to be cautious, but it is a very dangerous time. You know, if you saw in the video, most of the time when the horse is first brought in, there are people with the horse. But once the horse starts some movement, most people leave the recovery room. And most recovery rooms are going to be padded, padded walls, padded floor. It's like a padded stall because a horse may jump up and hit the walls. So a lot of times there's padding all around to be cautious. And you have to try to prevent the horse from standing too soon. So there is a technique that's called a rope assisted recovery that's sometimes done with horses. And when the procedure is done, now, sometimes people take the halter off a horse during surgery because, again, the halter can sometimes put pressure on facial nerves. If the halter's been off, you got to put the halter back on before they wake up. And you're going to put a rope on the tail, and there's going to be a rope on the halter. So there's going to be a rope on each end of the horse. The other thing that you can do, and sometimes this is done post-op in horses, is they'll put in what's called a nasopharyngeal tube. Now, nasal, it goes in the ventral nasal meatus, and it extends just to the pharynx. So this does not go all the way to the trachea. If you think they were having trouble breathing during surgery, or the doctor is worried about their breathing on recovery, this tube gives them a way to breathe, and it can stay in longer because if they're chewing, it's in their nose. They're not going to bite the tube. So you may pull the endotracheal tube early before they're swallowing and put in this nasopharyngeal tube. And with horses, pulling the endotracheal tube, they're not typically, they're not vomiting. So it's not kind of like what we worry about in dogs and cats. So it's a little bit different. You can put them in the padded area, and then you can provide oxygen with what's called a demand valve or an insufflation device. And I'll show that in a second. But here's a picture of a horse that's been put in the padded room. And usually what happens is now at Purdue, these ropes went out through a hole and someone was outside. This one, someone would be having to stand out here. But our ropes went out through holes and there was windows. And what happens as the horse begins to stand, you actually pull the ropes and it gives them some support. Like this. And then when the horse, and see what happens, and this takes a little bit of technique, if the horse was to start to fall one way or the other, you pull the rope one way or the other to try and give the horse some leverage. So a rope assisted recovery, you can't be in there helping this horse up. It's just way too dangerous. So you have to be outside the room, and the ropes are a way to kind of help the horse get up. Now, I told you that a horse that's going to get up premature, well, a horse, you saw this on Dr. Pohl's video, they typically throw their head first. Their head and neck helps lift them. So if you have to control a horse, there's a way to do it here. So now obviously this is if a 1,500 to 2,000 pound horse wants to get up, there's not a lot you are going to be able to do to stop them. But if you had a smaller horse, or when they're first waking up and they're pretty deep, you put your knee in the back of their neck. Now, you don't want to put it on the front of their neck. That's where the trachea and the jugulars are. But if you go on the back of their neck, they have a very thick nuchal muscle back here. And you're just kneeling on muscle. It's not going to hurt them. And usually you hold the halter and lift their head up. This horse can't throw themselves up. They can paddle and they can try to move, but if you have your knee on their neck and you're holding their head, they can't throw themselves up. So this is a way to kind of restrain a horse. You can try this in an adult horse initially, but if they start moving too much, usually they're going to get you out of the room. But in this case, they're showing the technique on a mini horse. And then here is a horse that's recovering with one of those nasopharyngeal tubes. And so they have this horse padded. They have a rope here. If you can see, that's attached. And what they've done is they've just put this tube in, which is smaller than the endotracheal tube, in the nasal meatus, and then they've taped it to the halter. So he can't, obviously, sometimes with these tubes, they try to sneeze. So it needs to be secure, but you can't tape it around the mouth. So normally you just put some tape around the tube. If you go to take this out, you'll usually they made them like ties, but you can like cut that tape and yank that tube out of their nose when they're breathing okay. Let me show something that's a little bit, make this make more sense. Let's see. Whoopsie. Okay. So this is a pretty cool video
waiters always look at me and think that I'm going to have a little salad, maybe a soup, and that'll be the whole meal. And when I do my actual
Okay, let me explain. So this is the New Bolton Center at the University of Pennsylvania Vet School, or Penn, University of Penn. This is probably the premier equine hospital in the United States. There's some good equine hospitals. There's Root and Riddle. A friend of mine worked down in Kentucky at this like premier equine that dealt with all like the expensive racehorses. They dealt with that racehorse Barbaro. This guy that's going to talk was the surgeon for that very famous racehorse. So this is like a premier facility, and it's talking about a pool recovery, but I want to show something, so I think it's a good one to watch. So,
my name is Steve Richardson. I'm Chief of Surgery here at the Bolton Center, and this is a 5-year-old mare with a badly fractured bone that goes up into a hock, which is the equivalent of your ankle joint, but in a horse, it's a really big and important structure. The reason that we're waking the horse up in the pool means the horse never has to go from being on its side under anesthesia to being up. It never has to stand up. Move that raft off there a little bit. Now, unlike humans, a really big risk in horses is them breaking the metal. I mean, this is a big horse. She probably weighs 1,300 pounds. So,
okay, what I want to show you now, this is still cool. The horse is actually in a raft in a pool. So the horse is not in the water. It goes in like the rubber, and then it's in the pool. But what the anesthetist is doing here, they've got the hand kind of over the eye. Here's that nasopharyngeal tube. But if you see this green hose, this green hose is hooked up to the tube, and then she's pushing a button. This is the oxygen demand valve, or the insufflation valve. The problem is that this horse is in a pool, in a raft, and it needs to breathe. And so the problem is this is kind of like a flush valve on the anesthetic machine, except it's hooked up to the nasopharyngeal tube. So she can hit that button and give like a breath of oxygen or fresh oxygen. Now, it's not hooked up to any gas. This is literally just oxygen. And so if you look back, I'll rewind just a hair, you can see her hit that button, and that's the flush valve, the demand valve. So if you have a horse, now you can use this in any horse that's in a stall, but it's particularly important for this horse because, again, this horse is in a pool, in a raft, and that's going to kind of prevent it from taking these deep breaths. So they are going to be able to assist the horse in breathing. So if I go back a little, you can kind of see it.
Is them breaking the metal. I mean, this is a big horse. She probably weighs 1,300 pounds. So it's a big, big animal, and you're still using fairly small bits of metal to put their legs together. So that is at risk, and that's the other reason we're waking her up. This pool system is the only one in the world. Okay, this is the only one in the world with this system. It has been modified over the years, but his idea has proven to be a very valuable idea. The advantage in this type of recovery system is that if you notice that the horse is not in the water. Okay, the horse is actually in a raft, so the horse is dry. Whereas the other systems, the horse is actually immersed in water. I would say the average time that the horse in the pool is probably about an hour, but the horses tell you when it's time to come out of the pool. They start to move their head. And when they start to really try to move their legs, that's usually the time to get the horse out of the pool. And still, they can do some really bad things, jumping up to their feet when they don't have their brain and their muscles and everything all coordinated. Because they're prey animals, the second they feel any fear, their sense is to jump up and run away. And that's what happens when they wake up from anesthesia. They're scared. They don't know where they are, so they're going to jump up to their feet as quickly as they possibly can. Oh, right there, stop, stop. As soon as she's up, she doesn't want to stand in that stall. She wants to go back to the barn where she can eat some hay. Horses are simple creatures. They want to eat.
Okay. Do you have any questions about that nasopharyngeal tube, the recovery? I mean, you could see how crazy that horse was starting to become. And that's the other thing I was going to talk about. in the lecture coming up, we only have a few more slides, but I'll probably end here in a few minutes, is horses can pretty much eat within a couple hours after anesthesia. They, you know, usually what we do the first hour or two, they have what's called a basket muzzle, and we put the basket muzzle on so they can get into their water bowl, but we don't want them to be able to grab food. And a lot of horses are going to try to like dig through their bedding and find, now normally they won't eat the straw that's in their bed because that's not what they eat. That's not hay, that's straw. But you'll see them kind of like use the little soft part of their muzzle sometimes to forage through the bedding to look for feed. But pretty much within a couple hours, usually by hour 3, they will eat because we want to get their GI tract going and get them fed. So, you know, in cattle, it's like 12 to 24 hours, but it can be sooner in an adult horse. So usually hour for the, you know, water just for the first 1 to 3 hours, and then their normal feed. And again, they had ropes, they had that lift, they're supporting the horse till they can still put weight on their legs. But the big thing I worry about, like I showed you last week in the video, when that one horse was waking up, you could see the nystagmus. And nystagmus is very common when a horse wakes up. And I feel like the crazier they are, sometimes the worse the nystagmus. But if they try to stand while they have nystagmus, you could see that horse, they follow their eyes. They're trying to find the horizon. And they're still not with it. They're still not completely, they're still CNS depressed. They're still coming out of stages. So once the nystagmus diminishes, that's when it's safe to stand. But you will have some horses that their brain, like he said, the brain and the muscles aren't really on the same page. Like the brain's like, I'm awake, and the muscles are like, I'm not awake yet. And they're not always communicating. So this is when sometimes we will give like additional sedatives post-op. If we see a lot of nystagmus and a horse that's trying to stand, we will usually give them something. So I am going to stop there. Do you have any, 6 new messages. I didn't see these messages. Okay. Any other questions?